We're starting in 15 minutes. Can anybody hear me?
Hello, John. We are here.
Hey, how you doing? Who's that?
I'm Juha is here.
Oh, good.
Good.
Oh, Juha, how you doing?
I'm fine. I'm fine. Thank you.
Okay, let me unpin this.
You have a new haircut.
Hold
John.
on, let me. I'm sorry?
You have a new haircut.
Yeah, I got shaved.
Yeah.
You know, it's hot in Miami.
How?
It's not good. You got a haircut too, right?
What is the temperature now?
Oh, it's hot. It's hot. It's, you know how it gets hot, 85 and muggy.
Yeah.
It's hard to go. It's hard to go
Hot and
outside.
humid.
You remember that, right? It's hard to go outside.
Of course, of course, of course. It is also hot here. China is getting hot now. It is 32 grades.
Oh, that's hot for China?
It is getting now more hot.
Is it muggy like Miami? Muggy like wet?
No, not that humid. It is not that humid. And in Miami.
Yeah. Here, yeah. It kills me. You know, University of Miami is starting to do a lot of webinars. They have Jacques.
Jack Marco.
Yeah, he's really pushing it. He's doing a lot.
Yeah.
I'm going to try to get him to do Spanish ones too.
Maybe they have some restrictions in hospital work, so.
Yeah, they could lead in Latin America in education. Yeah. They have a lot of Spanish-speaking doctors. Now you go to Latin America, mostly Mexico and Trujillo, right? Peru.
Yeah, Peru has a lot of COVID cases, and Brazil.
Yeah, Mexico is really bad. Mexico, Brazil. It's you see all parts of the world, but I do too. In Mexico, Brazil, it seems to be getting worse. United States is getting worse. It's going back again. Not bad, but it's not getting better. But we'll see here. How's Fitri doing?
Fitri is okay. Fitri is okay.
Indonesia has a lot of webinars too.
Yeah, tomorrow I'm involved also in one. Tomorrow, tomorrow evening, I'm involved tomorrow.
Oh, in Indonesia?
Yeah.
Oh, okay. We'll televise that too. We televise all our things.
Okay, okay.
Yeah.
And tomorrow is also the Annie is doing, Ali Christ from Arkansas.
Okay, okay.
Professor Yasaki is there. You are doing that.
I'm sorry?
You are doing with Professor Yasaki and Chris?
Yeah, I think so. I think we are.
Yeah. Yeah.
We are. You like the background?
Yeah. It's Miami Beach? Or?
Yeah, I don't make it too formal.
Yeah.
And now people are going on the beach, not too crowded now. They may shut the beaches again. They opened them up, now they close them down again. So,
Yeah, here everyone's wearing masks, and it is again
I'm
rather.
sorry?
We are controlled when coming inside the hospital, so you have to have a bag or cellular control, and you have to wear masks all the time.
Oh, okay.
Going outside still here, so because they are afraid. There were some new cases in Beijing, so they became more strict with
More strict? Well,
more
but
strict.
where you're at is not a hot spot, right? And in Henan, it's not
No,
bad
no,
there?
Hubei is our neighboring province, so there were not many cases in Henan.
Right, that's different.
160 cases have been here all the year,
Oh, okay.
but very strict discipline here.
Does it get cold like Finland in China?
Now it's getting hot. Now
Yeah,
it's getting
but in the winter, does it get cold like Finland?
Yeah, in the winter time, yes. Winter
Really?
time is, yeah, it's not that cold, but of course in the northern part of China, close to the Russian border or Mongolia, it is colder.
But nothing like Finland.
No.
That is frigid. Okay, Juha, we start in about 10 minutes, okay?
Okay, I'm ready.
I'll be back.
Yeah. Where can you see how many people are? Oh, that's it. Jesus, have 12 students. So teachers in Bible, they have 12 students. So now there are 13. That's good. This is the limit.
Hello, Professor. How are you?
Hello, I'm fine. I'm fine. Hello.
I'm fine, Professor. I'm from Suzhou. You know Suzhou? I am from Suzhou. Suzhou.
Oh, okay. Of course, this is beautiful city. Beautiful city.
Yeah, like before,
Good
like
job.
I came to know like
Venice
you
of
were.
China. Venice of China.
Yeah, it is in China.
Suzhou is Venice of China. Venice.
Of course.
There's many channels, and I have been several times in Suzhou. You have a beautiful silk factory there, and channels, and nice city.
No, Professor. I think like you have been to Suzhou. There is a two Suzhou. One is XUZHU Suzhou, and there is a SUZHU Suzhou. So maybe like
you have to be very careful in pronunciation in China. So Suzhou
exactly.
is close to Shanghai. Which I mean, this Venice of China.
Exactly.
And you are, where are you located?
I'm in Suzhou, XUZHOU, Suzhou.
Where is that? Which province?
It's Jiangsu province. Jiangsu.
Shenzhou. And this is?
You is Henan. Henan province.
Henan.
Henan. Yeah, I know. Like it is just by train. It is just fast train. If you take, then it's 2 hours or 3 hours it takes from here.
From Shenzhou.
Yeah.
Yeah.
So, I think Henan, yours is in Zhengzhou. Zhengzhou province.
I mean Shenzhou. Yeah.
Yeah, exactly. I know. I have been there once.
My background is from Henan Provincial People's Hospital.
Yeah, I can see, Professor. I can see that. So, Professor, how long have you been here?
2 years.
Oh, 2 years. Oh my God.
2 years.
It's really good. So, it's good. I'm doing your PhD now. Like before, like I did my master in neurosurgery, and then I continued for the PhD here. And this is my first year. I'm doing that.
First year you're doing PhD or
Yeah, PhD. The
on
first
which
year.
subject?
Professor?
On which subject you are doing?
Of course,
Which
neurosurgery.
subject? Hmm?
Of course, neurosurgery.
Yeah, but what kind of topics?
It's a glioma.
Glioma.
Yeah, yeah,
Okay.
it's going on.
5 minutes. Yeah.
So today is still like you are working, Professor?
Hmm?
Are you still working today, or is a festival?
No, it is holiday here. It is
Exactly.
this holiday, but I came to office to give a webinar. I had 3 webinars during the holidays, so I'm living close to the hospital. I come to my office to give the webinars here, so with my colleague Juha.
Yeah.
So it is how do you call it? What is the
Tuan Uche. Tuan
yeah
Uche.
dragon?
Dragon Boat Festival.
Yeah. You have a special prize, songsi.
Yeah, Chongsi.
Special food, songsi. Yeah.
Yeah, Chongsi. It's really, really very good. I ate just 2 times. Yeah.
Mhm.
Right.
But here in Zhengzhou, I don't think there's any dragon boat sailing.
course,
It is
yeah,
on
yeah.
coast cities.
Ghost?
And on the coast, seaside, you have to have for dragon boats or seasides, rivers, lakes.
River. No, it's a river. In the river, there is a Dragon Boat Festival goes on
Mhm.
in the river. In the
Okay.
Jiangsu, there is a Lianongguang. In the Lianongguang, there is only ocean. In Jiangsu, in Suzhou, there is no ocean. We don't have
No.
ocean.
No. Okay. The number here is not. We don't know. Hugo is here.
Moi.
Morning.
Miten menee, professor?
Kiitos hyvin, Hugo.
Onko kaikki hyvin?
Kaikki on hyvin. Kaikki on hyvin. Okay, we can soon begin. 1 minute.
Okay, you ready, Juha?
I'm ready. Yeah.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett from Neurosurgical TV headquarters in Miami Beach. We have the pleasure today of having Juha Herneziemi, a noted, famous neurosurgery educator. Well, I don't need to introduce him. I'll introduce him right away. Welcome, Juha. Juha, it's all yours.
Thank you. Thank you very much. Welcome all around the world to this webinar. I speak about olfactory and tuberculum cell meningiomas. I take my slides here. So this is the topic today to speak how to operate on olfactory groove and tuberculum cell meningiomas. I have added here Rosanna Romani name because she made her PhD in Helsinki on this on the anterior fossa meningiomas, and very good PhD. So I have operated once more. I have made more than 16,000 operations, half of them cerebrovascular, but I was surprised when Rosanna Romani studied also my meningiomas that I have done such a big number of meningiomas, more than 1,300 meningiomas. So I operated my first meningioma in 1975, and after that more than 1,300 meningiomas is my personal series. Here is one more than 10 years series of Helsinki, close to 2,000 intracranial meningiomas. So you can see that main part of the meningiomas are supratentorial, 83%, and 1/6 are infratentorial. Now we are speaking about supratentorial anterior fossa meningiomas. So I have added here to Rosanna Romani's figures my Kuopio data, which I had noted. Also, I have done more than 100 olfactory groove meningiomas, and 73 is from Rosanna Romani's PhD, 97, 2009, and tuberculum cell meningiomas 52, also until 2010. All these different series have been published in neurosurgery. So when you plan those studies, of course, there are special symptoms associated with these tumors. Olfactory groove meningiomas may grow rather large and cause personal changes, and then growing bigger, more posterior. They also compress the optic system, and in tuberculum cell meningiomas, they grow rather close to the optic system, and so the visual symptoms are the most common, not the psychological symptoms like in olfactory meningiomas. So you have to look at the vessels, arteries, and I think in these meningiomas you don't have to do DSA, but you do CT angio, you get good picture of the vascularization, and you know where it is coming. Then you have to take a look of optic nerve, chiasm, pituitary stalk, and on the hyperostosis basally in these tumors. And then you may guess of the tumor in MRI if it is soft, medium, or hard, like we classified these tumors. So this is a big, large olfactory groove meningioma, dislocating pericallosal arteries backwards and upwards, and they are on the surface of the tumor. I think this CT angio gives good picture of the vascularization and pushing the structures, arteries, dislocating the arteries. It gives good picture. And here we have also a large olfactory meningioma growing around both A1s, A-calm, and of course getting vascularization from these small arteries. So you have to be careful in that kind of tumor not to disturb the whole anterior cerebral artery communicating artery complex when you operate on these. This is a large olfactory meningioma with bony tubercle at the base, very typical in large tumors. So usually the arteries feeding the olfactory meningiomas are coming from here. And when it is that kind of bony tubercle, so the feeding arteries are coming through bone. So the hot drilling with diamond drill is one of the good ways to stop the bleedings. But you should go first to this part to stop the vascularization, and then the tumor surgery is bloodless. So there are different sizes of olfactory meningiomas we classified in our series, like with the same size like in AVMs. This is a small one, less than 3 centimeters in diameter. This is a medium one, 3 to 6 centimeters, and this is large one, more than 6 centimeters. So you see the distribution here. Large olfactory meningiomas, they were rather common in the series, and especially in the beginning of my surgical series in Kuopio, many old patients were found when CT came from the neuropsychiatric hospitals with huge tumors. So nowadays they are diagnosed more earlier, but of course in several countries like in China, India, Nepal, I have seen extremely big tumors also. And this is tuberculum cellae meningioma, like we classified with Rosanna romani, small, less than 2 centimeters, medium 2 to 4 centimeters, large ones more than 4 centimeters, all in MRI. And this, of course, cause optic tract compressions because of their site early, and they come earlier with symptoms, except we had one patient who was totally blind and had a huge fist-sized tuberculum cellae meningioma. So this is the lateral supraorbital approach. It looks a little bit maybe too small in this drawing. In the practice, I try to do it 3.5, 4.5 centimeters, usually less than 5 centimeters in size is the approach. And I go, as right-handed surgeons, I like to go from the right side, but of course if the tumor is growing very much on the left side, so I go from the left side. And here are the attachments of the tumors where the tumor is growing. This tumor is growing here, close to the olfactory bulbs, and here is the tuberculum cellae attachment. So this is how it is. Here regular, and here a little bit more temporally open. I don't see. Oh, this is left-sided. So this is left side. So this is here is a more temporal extension, and this is the regular lateral supraorbital approach, which I began to do in 80s when I noted that in my external approach, the patient had terrible muscle atrophy. So I wanted to avoid the temporal muscle cutting, and I also noted that this temporal site was used by far less in approaches to aneurysm. So I have done it many thousands of times, so I'm very familiar with this approach. I'm well aware that many of the olfactory meningiomas, like here in Chengzhou, in my own hospital, they are operated by frontal craniotomy, and you are making a lot of work with the frontal sinuses to come in totally in front of the plate. So here are some schematic drawings from our publication from 2005 when we published first time this technique after having done it thousands of times. So incision is shorter than the regular bacterial approach, and we are not going close to the zygoma, and only very little of the muscle is cut, and this is regular size of the flap. So you see it's around 4 centimeter flap. I don't like to make it very small because it's not good for the surgery. You have to have enough space to with your light and instruments and to change the angle to come different parts. There's one more. The picture of the lateral supraorbital approach. I make it one burr hole here. I couldn't, as resident, I couldn't understand why are you making here the burr hole where it is most difficult to do with the bony tubercles, sphenoid wing. So I began to do here the one burr hole and then make 2 cuts, and we will see in the videos that. So in large meningiomas, anterior foci go under the frontal lobe and go laterally to the tumor to open the basal cisterns. Then you get CSF out, and then I go to the bulk, the tumor, go to the base of the tumor, in this case olfactory meningioma, which gets feeders from the anterior fossa floor, middle part, and then coagulate them quickly, and then usually the rest of surgery is bloodless. So here is a large olfactory meningioma. The patient had psychiatric symptoms, and you see that, and also no smell. She couldn't smell anything, so you see that the olfactory nerve is atrophic. Later in the series, I always tried to save the olfactory nerve, even if it is that kind of small, but I was not in giant or large olfactory meningiomas, I was not successful, but in small olfactory meningiomas, I can usually save at least the contralateral olfactory nerve functional. And then you have to take care of the optic nerve. This is tuberculum cellae meningioma. You see atrophic optic nerve pushed by rather small tuberculum cellae meningioma, and then you might have also perforators coming from the anterior cerebral artery, some of them feeding the tumor, but some of them should be saved. So I go to videos now. I show 4 videos of olfactory groove meningiomas, and then 2 on tuberculum cellae meningioma. This video is edited by Jiang from China, my fellow. So rather small tumor. Right-sided lateral supraorbital approach. I go to basal cisterns and take CSF out, and at the same time I dissect. This is the olfactory nerve. I dissect it. But when I look here, I should dissect more posterior here, because now it is under stretch. But you go above the olfactory nerve to the tumor if you want to save it. Of course, you may lose the olfactory nerve by, it is very fragile, so you may lose it, or then the tumor is growing to close to the olfactory bulb, so you lose the smell when the filaments are olfactory are destroyed. But here we go to the tumor surface. I retract frontal lobe with what happened? It stopped. I go inside the tumor, and you have to go to the basis of the tumor to coagulate all the feeders. This tumor, even if it's rather small, looks well vascularized. It looks rather soft, so you can suck it, and you coagulate, and make the tumor smaller, and then you get a good grip on the tumor, and you can rotate the tumor a little bit if it is that kind of small tumor, and now sucking the tumor away, and all the time debulking the tumor and pushing it to the floor of the anterior fossa. Now you see that the upper part of the tumor can be seen, and then you coagulate carefully the small feeders. You get the feeling when which part of the tumor you can draw out. You should not draw abruptly, because then you have some artery bleeding and difficult to find in the small cap. So coagulate the tumor, and now tumor is out, and this was the end. The end part was not well edited in this video, so you should take a very good care of the hemostasis. Here, next one, this would be a bigger one, medium-sized, edited also by Jiang, Chinese neurosurgeon. I don't remember which city he was coming. Here, a bigger tumor. This may already cause some psychiatric symptoms, and many times they have lost they have anosmia. Right-sided lateral supraorbital approach, opening the dura, and then going frontobasally and lateral to the tumor. I open the cisterns and get CSF out, and then you have your more space. Of course, in Helsinki, there was excellent anesthesia. The brain was always slack. And now going inside the tumor, coagulating the. In the beginning, it is bleeding more, but when you coagulate the feeders at the base of the tumor, then it is getting totally dry. We have never embolized these tumors. I don't see any indication for that in these tumors, because you know exactly where the feeders are coming, and the feeders are many, and they are rather small in caliber. So best is to debulk the tumor and at the same time coagulate the feeders from the base. And the shaking in the picture is coming from the mouth switch, which I use in operation. It makes the operations very fast, reduces operation time 40-50 minutes. I cannot understand why not more neurosurgeons are using this one. And, here, small arteries from the basal arteries going on the tumor, partially feeding the tumor. So you have to take a look. This is the very high magnification, so the arteries look huge. This one I should save. This one I should save. Yeah. This one I should save. It's feeding the tumor. attached to the tumor. No, I coagulated. This was not well done. I should have saved it more to be more patient here, maybe. Anyhow, the patient had a good outcome. And so now we push the tumor all the time down. After debulking, I inject usually water between the brain, and here was a bony tubercle. So this is the diamond drill I mentioned. So I drill it, and this is the cavity now, and this is a post-operative picture. So it looks good, and the patient made good recovery. And then we have a larger olfactory meningioma coming here, edited by Juha from Peru. This is a large olfactory meningioma. This gives psychiatric symptoms, and as I told you in the beginning, when the CT came to Eastern Finland, so we could find many patients placed in psychiatric hospitals with very large tumors. So opening and drilling the bone basally, and then going again to basal cisterns laterally. And this is we saw this picture here. You see the atrophic olfactory nerve. This one you can sacrifice, but if you try to save the olfactory nerve, so you are working more tender. This is how I do after debulking of the tumor. So I inject water, water dissection, injecting water between the tumor and frontal lobe, brain substance, and then taking basally tumor out. Now you see that the small olfactory nerve will be lost. In this case, as mentioned, I can save it in small olfactory tumors, at least the contralateral one, and sometimes also the ipsilateral one. But to save ipsilateral by this approach is more difficult. You can, of course, make a midline approach to save the olfactory nerves, but it is also not so easy, because if the tumor is attached close to the olfactory bulbs, so you have to evaluate the dislocations may also cause anosmia. So this is a cutting of the valves in large tumors. You have to cut the valves and sometimes also drill the crista calli out. Now with the big scissors, I make the tumor smaller. You are not taking, of course, in one piece that kind of big tumor, so you have to take it in pieces out, small pieces out. Here I drill bony tubercle, cut temporal muscle on the skull base, put also glue and hemostat there not to have CSF leak. I will come back to the numbers of CSF leaks, but they were not so numerous. They were not many, less than 10%, 5%, I think. We will see the figures. So carefully taking care of the skull base and then careful closing, and these are the post-operative pictures in this case. And then we have one more olfactory meningioma. This is a recurrent olfactory meningioma, edited by Jane Lau, Hong Kong neurosurgeon, was my fellow. And you see the recurrences, number of recurrences. Also, I will give the numbers. Here you see that it is mainly growing inside the nasal cavity. Nowadays, maybe you could do it by endoscopic surgery from below, but I don't have that kind of skill. So unfortunately, I was never learned transsphenoidal surgery. And this is how I do the ring craniotomy. I open carefully here under microscope, drill, and then break the bone plate out, and you see a lot of scarring now. This is why the ring craniotomies are not so easy to do like you may estimate in the picture. So there's a lot of scarring and difficulties. So I used to do the opening totally under microscope, not to destroy the brain, because there is scar and revascularization. You may lose important cortical arteries when you are opening without microscope. So this is important. So also to dissect to the place of the tumor is difficult. And now we are coming to the tumor growing in the midline and to the nasal cavity. And then opening skull base with diamond drill, and then taking all the tumor out of the nasal cavity. And then of course we have to make a careful plasty on the floor of the anterior fossa. Tumor is coming, strong forceps, drawing the tumor out. Then how to make the plasty on the anterior fossa. I take the bone plate from the craniotomy bone and then place it with fascia lata, make a sandwich of that, and actually put usually two small bones and then fascia lata, like a sandwich or hamburger. It's good to put a spinal drain in these cases, so not to have CSF leak when you have that kind of big opening. Here you see the bone plate placed and the patient recovered well. So now we come to the tuberculum cell meningiomas, which are smaller because patients will have visual field deficits or seeing it disturbed. So you see the tumors are smaller, they compress the optic nerves, and opening again the same. Of course, here you don't have to think about any temporal extension. It is more used in anterior clinoid meningiomas, which I will speak next week on the anterior clinoid meningioma. So again, going down, dissecting under high magnification. How do you know this is extremely high magnification? Because the microschissors look like crocodile, extremely big instrument. These are the classical Yasakil microschissors. And now we are coming to the tumor. This seems to be rather soft, and this bleeding still. Bleeding also looks terrible under high magnification. You will see how much the bleedings are. There's good statistics on the bleedings. So you have to take care, of course, on the both optic nerves, carotid in bigger tumors. Now you see that I'm rotating, the tumor is coming out now. And then this is tumor forceps grasping the tumor. somehow it is bleeding a lot. It's very, very vascular. But when you have the tumor out, then you will have bleedings stopped. Of course, here you have like always make an extremely good hemostasis, but it was rather vascular. Of course, very fast operation. It doesn't bleed so much, and here is the biggest part of the tumor is now coming out. The bleeding is now already by far less after coagulating the feeding arteries. Some of these tumors grow inside optic channel. You can see it many times in MRI. In these cases, I open the optic channel, but not routinely, like some have recommended. Now it's getting more clear. Still bleeding, still bleeding. And then I put usually fibrin glue at the base where the origin of the meningioma, and then we are ready to come out, and patient had good outcome. And these are the postoperative pictures. Hemostat looks like blood there. Then now this is a case. There were the patient had meningiomatosis, had several small meningiomas, and then right frontal meningioma, and also this tuberculum cellae meningioma. So 2 of them were operated, or 3 of them were operated in the same time. So the incision is a little bit more posterior here, because we have to take 2 meningiomas out, and the frontal meningioma is here. I make here, exceptionally, I make here tuber holes. The bone looks rather thick. You see that I'm using extremely short instruments. I cannot understand, for example, here in China, the local practice that you have extremely long instruments also when you are working superficially. Of course, the Chinese and Japanese, Asian people are used to eat with chopsticks, so they have good skills in their hands. But even so, I cannot understand why are you operating so far away. So epidural bleedings are stopped carefully, and then you have to take care of all the bleedings in the opening. And now we are frontobasal already. Here the dura is, you see the right optic nerve is compressed by the tumor. Again, going to the base of the tumor, and then pushing the tumor down, anterior fossa, and here you see that it is rather hard tumor, and there is not very much attached. to the compressed optic system, so I can, after debulging, I can rotate the tumor, and it's coming like a small ball out. That had not that kind of heavy vascularization. So I can draw this small ball out after debulking, and there's some part of the tumor still left coming out. You have to check carefully that you don't leave some small parts of the tumor there, because they will grow and give recurrences then. And then very careful hemostasis at the base. Hemostat going to the floor of anterior fossa, and the meningioma, the bigger meningioma, was also taken out. So these were the videos, and then I have some statistics of the cases. So when very important in, especially in large tumors, is to go early to the feeders in olfactory meningiomas, tuberculum cellae meningiomas. This is statistic of Rossana Romani. So you have in her anterior fossa tumors close to 200 patients, and these all were operated by me, and the average loss of blood was 2 deciliters, 200 milliliters. In one case, there was extensive bleeding. It was a huge vascular meningioma, but otherwise, we didn't reserve any blood for these operations, and very few patients, on less than 10%, needed blood transfusion in these cases. And here are the operative times. We count operative times from skin to skin, from incision to the last stitch. So the average in these close to 200 cases were 150 minutes. Range from skin to skin was 35 minutes, of course, very small tumor, and then one very long operations. This gives 7 hours with a lot of vascularization. So the time of operation was not related to the tumor consistency, but related to tumor size. And this is, of course, clear. If bigger tumors need more work and time. Then there were 9 CSF leaks, 6 in olfactory groove meningiomas. 3 of them had ready ethmoidal infiltration by the tumor, and there were 3 leaks in tuberculum cellae meningioma. So altogether 9 cases, 6%. So these are, of course, they mean that you have to reoperate when the leak is not stopping very quickly with the lumbar drainage. And then there were 4 meningitis in these cases, no flap infections, and in some patients we lost functional smelling, new anosmia in olfactory groove meningioma, 6 cases, and tuberculum cellae meningiomas, none of them lost smelling. None of them became totally anosmic. And then about the visual outcome, new deficit in olfactory groove meningiomas. There were 5 patients, and no out of the tuberculum cellae meningiomas. Actually, of course, many patients had their visual outcome improved. especially in tuberculum cellae meningiomas, where the most common symptom is compression, from compression of the optic system. And also here, it was not related to tumor size or consistency. Some of the tumors, tuberculum cellae meningiomas, are very stuck to the optic nerves. I remember one famous artist had this tuberculum cellae meningioma, and I had big difficulties in getting all the tumor out, and I was fearing to death during the operation that he will lose his eyesight. That was not the case, even manipulation. In olfactory groove meningiomas, none of them died. So zero mortality, some morbidity, as you have seen. And in the tuberculum cellae meningioma series, there was one death 40 days after surgery. After good recovery, the patient died in myocardial infarction, and we count this also as a surgical death, even the patient was doing well after surgery. So less than 1%. Then some patients had residual tumor in control MRIs. In olfactory groove meningioma, 6 had residual tumor, 3 were reoperated, 1 had radiosurgery, and 2 small residuals in all patients were followed up. And then tuberculum cellae meningiomas, around the same. 2 were reoperated, 1 had radiosurgery, and 4 small remnants were followed up. And recurrences, in these cases, the follow-up time was more than 10 years, very careful follow-up. So recurrences in 5 cases, olfactory meningiomas 4, 2 were reoperated and 2 were followed up in old patients, and then tuberculum cellae meningiomas, 1 was reoperated. So concluding, I have done this approach, lateral supraorbital approach, thousands of times. For me, it is very well suited for anterior fossa meningiomas. Whatever the sizes, giant olfactory meningiomas are very well taken out through this small approach, one-sided approach. And one of the advantages here is that it is extremely fast to do as compared to bifrontal craniotomy, where the opening takes the same time many times as I have seen. The opening takes the same time than I have done all the operation from skin to skin. So I heavily recommend this approach because it is simple, and if you can do it well, then you are familiar with the anatomy and you will have good results. So this is once more Dr. Drake, great neurosurgeon, my teacher, excellent neurosurgeon, good medical doctor, and also good human being. And this is very difficult, of course. And this is like, I showed this picture because this looks like my first teacher, GP in the small village where I went to school. He had taken 50 years of all the patients' care in the small village. And this is how we are many times in neurosurgery. Also in neurosurgery nowadays, we are thinking what to do with the patients. Patients have many times terrible diseases, heavy bleedings, traumas, so we don't know how to do. And you see the father of the girl is here behind. We have to take care also of the families, and this is very important to be a medical doctor besides neurosurgeon. This is from operation room in Helsinki. This is Dr. Rosanna Romani assisting me here in meningioma operation. So it is easy to speak and criticize the surgery. But in operation room, you have to walk the walk, not to talk the talk. So you are faced every time, even you are experienced with new challenges, and you have to prove every time that you are doing in this case well, because you don't get the second chance in an individual patient. And this is Dr. Rosanna Romani, who made the statistic of the meningioma operations very good, and a very good PhD. She is nowadays working in Great Britain. So I thank you very much. And maybe you have some questions, CJ.
Very good. Thank you, Juha. We have a lot of inquisitive faces here. I'm sure we have questions. So, okay, it is now open for questions or comments for Juha. Someone be the first.
Juha. Hello, Juha.
Hey, hello, Louis.
Juha, I'm Yunhong. Very nice to meet you, because sorry, my camera is not working. I have a question before.
Who's speaking?
Yunhong. Sorry,
Okay.
my camera is not working. Sorry.
Go ahead. Go ahead.
I have a surgery about meningioma, sphenoid plate meningioma, small, about 2 millimeter size. I have surgery from right frontal craniotomy, but the patient after post-operation, the patient left vision loss. I don't know.
It was 2 centimeters. Certainly, the tumor was 2 centimeters, not millimeters. These tumors may grow. Tuberculous cell meningiomas may grow inside the optic channel. So you should look carefully, and in these cases you should open the optic channel. Next Friday I can show that kind of cases, how they grow inside the optic systems. I read someone is recommending that you open routine the optic channel, but I don't think it is good, because sometimes you may also have difficulties in the optic system when you open the channel. So it has own complications.
Do you think is visual loss is some bipolar somal damage?
It's coming from, this maybe there are small perforators going to optic system. So if you coagulate them, and of course you may lose the vision. It is also possible. So I cannot say, of course, from far away. Compression, you should be careful when you are the tumor out. So all the movement should be away from the optic system, and then take under high magnification you see even the smallest arteries. So I try to save them very carefully, all of them.
Okay, sir. I will send this case to you, and after work I will send this case to you.
But you had operated on it already.
Okay, thank you.
Okay, thank you very much, Juan. Which seat you are?
Okay, Louis, you had a question? Go ahead, Louis.
Yes, good morning, everybody. Good morning, Juha. Fantastic. I totally agree in the most of the case. Today is not necessary embolize the meningiomas. See, you have a very good neurosurgeon. Probably the embolize, sometimes you are the high risk previous to surgery. I think it's not need. But if you want to have one case, complex case, and now I use onyx to embolize the meningioma. It's a representative case. It's only a case of the bigger or complex meningioma. Do you want to see the case, Juha?
Do we have time, Luis?
Yes,
Sure, we have time.
it's 3 minutes.
Okay.
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 Okay, a ver, I don't know where it is. Just a minute. Here. Yes, it's here. Is young man. Just a minute. This is in the beginning. Okay. It's a large meningioma.
Yeah, it's a very nasty and terrible looking tumor growing.
Yes, and involved the middle cerebral artery.
Yeah, yeah.
And edema. It's treated before about 10 or 12 times with surgery. It's a recidivant meningioma. This is the first MR. 6 months later, one control MR, the meningioma growth in the base of the temporal skull in this portion. I have a second meningioma, small part here, and it's involved the siphon and cavernous region. The angio is AP view. The middle cerebral artery is involved, and you have the collateral leptomeningeal circulation. The patient don't have a deficit. In lateral view, you have the stenosis of the siphon. You don't see the middle cerebral artery, and you have the meningioma around the cavernous and ophthalmic, many feeders. I decide to treat to help for neurosurgery. I have a check testing with balloon test in the carotid, internal carotid left side to see the collateral circulation in the siphon. And I decide to close with coils, packing the distal part of the siphon just before the ophthalmic, and then injection in the ophthalmic artery, onyx, also in some brains in the external carotid, but the embolization is totally with onyx. This is after. I help every time you the choroidal, anterior choroidal artery is still open. This is the most important. This is CT after embolization. You see the cast of onyx. And this is after embolization MR. This is the no contrast enhancement. This is the part embolized with onyx, and this is the residual part of meningioma. In AP view, don't touch this part because you have a high risk of lesion. This part is totally controlled by onyx. Lateral view. After embolization, pre-embolization, this is the deficit, and hemiparesia. After embolization, have improved the frontal syndrome, I have only the very high pain, maxillar pain, secondary to ischemia with the onyx. And the patient going to surgery. This is after surgery, remove, total remove only this part, remove the tumor in AP view, remove the tumor. This portion is not touched. The patient is still well about 2 years, but 2 years later have a new meningioma and death. This is a case to learn for you. Thank you.
Thank you very much. This is, of course, a totally crazy case because it has been operated many times and the tumor is coming back and growing in the skull base. So it is very useful in this case to have embolization and preoperative embolization. And maybe you can even, with your embolization, you may heal. Anton Valavanis showed me in Zurich one case, one Italian patient, Nobel Prize winner with clival meningioma. He could treat with embolization, the tumor disappeared totally. So it has some power, endovascular preoperative embolization. So in special cases, it might be extremely useful and make the main part of the tumor necrotic and like yogurt coming out then in the operation. It is helpful. In difficult cases, desperate cases, you have to use all the possibilities to have good results.
Okay, very good. I believe Hugo Andrade has a question. Go ahead, Hugo.
Hello, Professor.
Hey.
Hi. Sorry. Go
ahead, Hugo.
Yeah. So just one thing, because Juha showed the timing of the surgery. So normally we close the patients under the microscope. So you can see the time is not so long either. That's a general practice that we do.
Yeah, this is a good point. So we are using the mouth switch and we are closing under microscope. So it is not making the operations longer, like it is many times claimed. So like Hugo is good in closing, and I have not closed long time because the fellows have closed. To learn to use the mouth switch, it takes around 6 months, 6 months, but it pays back in time. The fast operations, you can do more operations a day, and then it is not expensive tools. It is around $3,000, the mouth switch for microscopes. So it's one of the best things for microsurgery, and very few, less than 5% of the neurosurgeons are using it in the world.
Okay, very good. More comments, questions?
Yeah, may
Go
I
ahead.
speak?
Please introduce yourself.
Yeah, is this clear? My voice is clear?
Yes, it is.
Yeah. I'm Redab. It's just certified neurosurgeon from Jordan. I contacted you, Dr. Juha, recently, and you were very kind. I do appreciate your response, and I do appreciate your great presentation. Just to make it short, first, can you please tell me or tell us what exactly the superior aspect in the lateral supraorbital approach over the pterional approach? What do you see is more different and superior or advantages?
More different than, you mean advantages? Very fast, simple approach, very fast. Like I'm in 10 minutes with my experience. I'm in 10 minutes from skin incision, opening the dura, or many times dura opened already. So it doesn't take long time.
And
it's less traumatic, I mentioned why I switched to lateral supraorbital approach from pterional approach was because of young lady. She had MCI aneurysm ruptured. I operated on. She made good recovery in 2 months. I operated contralateral MCI aneurysm that was diagnosed already when she had recovered. Then after 6 years, she came back with the ruptured pericallosal aneurysm, de novo aneurysm. And she looked terrible. This young, beautiful lady, she looked terrible because of massive bilateral temporal muscle atrophy. So I switched because of this patient to do less a traumatic approach. And I've learned to do it fast. And I will show next time, next Friday, I will speak. So I will show video just focused on the opening. So I will speak on the anterior clinoid meningiomas next week, and then I will show, in association with that, I will show the lateral supraorbital approach, which is good. In Finland, we don't have big eyebrows like in Jordan or Turkey. So the females at least don't love to have eyebrow incision or nothing here because the eyebrows are very weak. But in Iran, my fellow Reza Dastia, we were joking that you could do bifrontal craniotomy through his eyebrows because they were so thick and strong.
Yeah.
But this is also, you have to select your approaches locally. But the eyebrow incision, the anatomy is different than in the lateral supraorbital approach. So it is, I have tried everything. And there's a lot of publishing, very small approaches. You are competing with how small approach you can do. But I don't think it is wise because the patient is paying if you have complications. So it is not wise to go to big vascular lesions, aneurysms to operate on through extremely small approaches or vascular tumors. So because you have to have many angles and you have to have your instruments and the light through the opening. So this is, my limit is opening is around 4 centimeters.
Okay. Thank you. Thank you so much, Doctor.
Thank you.
I appreciate it.
Okay, more comments, questions from the panel? Well, I'd like to take this opportunity, Juha, to introduce Ibrahim Solomov. He's a resident from Tyumen, your friend Alfred's place in Tyumen, Russia. Are you there, Ibrahim?
Hello, everyone. Hello, Professor Juha. Hello from Russia.
We have met when I was in Nepal. You were in the Ayapsherians.
Yes.
Ibrahim won a neurosurgical skills contest to get into Tyumen, and he's also very, very smart on social media. So you're going to be hearing a lot from him.
Professor, hello from Russian Young Neurosurgeons Association.
Where are you working in Russia?
Where are you? Now in Tyumen, but
Tyumen. Okay.
But soon I'm go to Moscow.
Yeah. No.
Yeah, we hope to keep in touch with him.
Yeah. Of course. I would love to come to Tyumen. I was once invited, but I didn't come. That I couldn't have that time and possibility. And now the world is closed, so you cannot make any plans. At least for this year, next year, it's also open. Let's see how the world will open.
Yeah,
Okay,
we'll be back. Okay, more comments or questions from the panel before we close? Okay, well, thank you very much, Juha, again, and we look forward. You mentioned the topic possibly next week, correct?
I will speak about anterior clinoid meningiomas through lateral supraorbital approach, and if Luis has some terrible cases, so please.
Louis, do you have any terrible cases? Okay.
Or no more. No more.
No more.
Thank you.
Only the successful ones, right?
So, bye-bye.
See you next week. Bye-bye.
Okay, thank you
Bye-bye,
very much.
everybody.
Thank you very much, everybody.
Bye-bye.
Bye-bye.
Bye-bye. Bye-bye, John.
Okay, thanks everybody for coming. That was good. That was good. So Abraham, you're going to Moscow.
Yeah, but here you
Yes.
have to wear masks.
I
When you go
Oh,
out, this obligatory here. Everybody's wearing masks here.
Everybody, yeah, in the hospitals too.
No, outside in the city.
Oh,
In the
okay.
city, everyone is wearing masks.
Oh, okay.
You feel that you are a criminal if you don't forget your mask. Okay, bye-bye.
Thank you, Juha.
Thank you, thank you.
And thanks everyone else for coming.
Thank you, Dr. Bana. Thank you.
Okay, have a good day, Abraham.
Thank you, John.
Young Hong, thanks for coming.
Yeah. Because my camera is not working still.
Okay, thank you very much, Young Hong. Okay. Superman.
Superman, Super Chinese.
Superman comes.
Thank you.
Okay, we'll see you.
See you.
Okay. Abraham, how's your organization going? The Young Russians.
Now we working very slowly and so slowly.
Yeah, not much time. Well, let me know if you want to televise something.
Okay.
I would
Okay.
love to.
If we have a topic and people which want to presentation, I say.
Yeah, just let me know. Just say I'd like to do a presentation. The Young Russians want to do a presentation, and we just do it.
How are you, Dr. Bennett? How are you?
Oh, very good, very good. Getting
Thank
busy.
you very much for your work for young.
Oh, I love it. I love it. It's getting more popular because of Corona. Before Corona, people didn't know what this platform was, but now they know. I don't have to explain. Many times to older neurosurgeons, I have to explain what it is. But now, no, people know. People know. It's probably the same in Russia, right? Everyone's communicating with video. It's the same, I think, in most of the world. But you're in the second year, right?
Yes, I'm second year and final year. I'm final my residence in Tumen and go to Moscow for continue, but is not residency Russian, as aspirantura. Aspirantura is maybe like continue to residence, but in scientific residency maybe. Aspirantura name. Aspirantura name.
Oh, okay.
And Pirogova Center with my love operations or epilepsy surgery. More epilepsy surgery in Pirogova Center.
Oh, really?
And,
is that part of Burdenko?
Yes, no, near very close in Moscow, Pirogova different, but two good center the big center. There, Professor Zuyev, Andrei Alexandrovich.
Oh, okay. It's a big epilepsy center there, and
yes,
in Moscow.
I will learn with Professor Zuyev.
Like a fellowship for a year.
Yes, like fellowship. 3 years aspirantura.
Oh, 3-year fellowship. Wow, so long. That's different.
Yes.
Different education, different structure.
Yes, we will write science articles and then dissertation
Oh,
tomorrow.
very good. Well, very good. Okay, let me know if you need anything, Abraham, okay?
Okay, okay.
Okay, we see you again.
See you again.
Okay, thanks everybody for coming. Oh, I gotta end that.